Hello, my name is Tetlow. I'm a clinical exercise physiologist at UCLH, a Perioperative Medicine Master student at UCL, and a researcher in the Human Physiology and Performance Lab. Today I'm going to present our group's work on how preoperative metabolic inflexibility is associated with the development of postoperative morbidity. The association between fitness and perioperative outcomes is well established, however its mechanisms remain underexplored. One explanation implies an underlying cardiac limitation causing reduced oxygen delivery, i.e. a central limitation. However, in deconditioned individuals, exercise capacity is limited by mitochondrial oxygen uptake rather than cardiac output, suggesting a peripheral over central limitation. This peripheral limitation is associated with metabolic inflexibility and is characterized by a reduced capacity for lipid and glucose oxidation in response to changes in metabolic demand. We therefore hypothesized that patients who develop postoperative morbidity would demonstrate impaired substrate utilization. To test this, we derived substrate use for lipid and glucose during CPET and analysed these profiles in reference to the presence or absence of POMS-defined morbidity and or discharge from hospital on day 7. Of the 107 patients identified, there were no significant differences in CPET variables between those who did or did not develop morbidity, as in Table 1, except for the VE/VCO2 slope. When we plotted metabolic flexibility curves, we observed distinct visual differences in substrate use. Note how both the profile of fat ox in blue and carbohydrate ox in red is blunted in Figure 1b for the any morbidity group as compared to the no morbidity group above in 1a. These profiles demonstrate differences in the ability to appropriately increase substrate utilization in response to changes in metabolic demand. We observed significant differences when comparing median substrate utilization rates. In Figure 1c, fat ox in the no morbidity group was 0.165 grams per minute, whereas in the any morbidity group it was significantly lower at 0.113 grams per minute. In Figure 1d, carbohydrate oxidation in the no morbidity group was 1.158 grams per minute, whereas in the any morbidity group, again, it was significantly lower at 0.994 grams per minute. In conclusion, patients who developed morbidity demonstrated impaired substrate utilization. Metabolic inflexibility may therefore be a novel candidate mechanism for the development of morbidity, and assessment of metabolic function using CPET may be able to identify the at-risk patient. Further research is required to understand this mechanism and may provide opportunities for targeted interventions such as exercise, diet, and pharmacotherapy. Thank you for listening.